All right, good morning, good evening, good afternoon, wherever you are in the world. My name's Mick Hughes, and this is one of our latest and greatest ACL Hub interviews. And I'm joined by one I'd say I'm a huge fan, and certainly I model a lot of my physical therapy practice from this great man, Mr. Erik Meira. Eric, welcome to the ACL Hub, and thanks for joining me.
Thanks for having me, Mick. It's really always a pleasure to talk to you. I'm a big fan of yours as well, so it goes both ways.
Oh, mate, appreciate it. I've yeah, I've appreciated everything you've done for the last few years, and I've been lucky enough to be in a position where I can cherry pick a lot of great people's wealth of knowledge and experience, and you're certainly high on the people that I quote each and every day. So it's nice to be able to have another conversation with you. We've had a couple of chats, and I always learn so much from you and your experience. So yeah, I'm grateful, and hopefully everyone that's listening today, both patients and also to professionals, health professionals that are joining on the ACL Hub, learn a lot too. So, mate, I won't butcher your bio and introduction. I might let people, those that don't know you personally, I might let you give a little brief intro rather than me tell a terrible story. I'll let you just give people a rundown of what you do and what you maybe some of your experiences are before we get into it.
Yeah, I mean, probably one of the least typical paths to where I am. I've been a physical therapist and over here in the United States since the late '90s. So what's that, 25 plus years now? Most of my focus has been in sports medicine side of practice, but also worked a lot, with professional associations and that kind of thing for the profession. Um, Again, mostly sports medicine. I have been very open public in my thinking,
Yes, good.
meaning I've been notorious for thinking out loud and trying to just, kind of asking questions and kind of trying to push the profession forward, and been doing that for a long time. I do a lot of, from the clinical side, I do a lot of consulting for, different teams, whether at the college or the professional level, or specific athletes that will contact me to work with, mostly at the professional level with that. Otherwise, I put on some conferences. I do a lot of continuing education. I have an online platform for physical therapists, athletic trainers, those types of professions to engage with, and just trying to give a platform for people to, just think more, I guess.
Oh, it's wonderful, man. And you like to fly planes too, so it's
Yes.
another
Yeah,
little
and if you want to
side
learn how to fly
project.
planes, I'm building an online ground school for that as well. So, but
Oh my
that's a side job.
Lord. How many hours do you have in a week, mate? You must have more than me.
Yeah, I don't
That's
sleep
one
much.
that's wonderful, mate. I love it. I love it. And I love, yeah, your just your I guess the depth of knowledge that you're happy to share and your generosity. So no, I appreciate you. This may be a very, very short question. Hopefully there's a little bit of beef to it. But do you have a philosophy when it comes to ACL rehab, or a particular way about going about your business? I was talking to some fellow clinicians before, and some people are taking this reverse engineering approach, so to speak, where they kind of think about the end first. Like, do you have a particular method to your madness, or is it you kind of just sort of treat every person as they come through? What sort of goes through your brain when someone walks in day one with an
Yeah, I mean, a lot of what
ACL?
I teach now is that, the hundreds, probably getting up into the thousands of ACL reconstructions that I've seen in my career. I've never had one, never
Mm,
gone through it myself. Of all the ones I've seen, I don't know that I've seen any two go exactly the same.
yeah,
So that's kind of a thing to kind of keep in mind. I like to point out that the organism in front of you is a lot smarter than you are,
yeah,
and it'll find its own ways. And so, what we're trying to do, really, my philosophy would be, I guess thinking about the end stage, the end game of it is important. Of what are the common issues that we're going to have towards that end stage, and then how are we kind of tracking that, and then also stimulating that. I think where people get things wrong a lot of times is thinking that we can really drive a lot of the change as much as we are kind of poking and prodding and just trying to nudge things in the right direction, and then just tracking and watching as things go. More as a role of keeping things honest and
Yep.
trying not to fool ourselves.
Yep. And with that, keeping things honest and tracking, I assume that's testing, retesting, objective measures, patient-reported questionnaires. Is that the kind of thing you're talking about, just to make sure?
Yeah,
Yep.
for sure. And the testing is really, really important, but I've also seen people take that to the wrong extreme where they're like, it's a black and white, did they pass the test or not?
Yep.
Pass the test good, didn't pass the test bad. The way I like to think about it is it's always, the whole process is actually it's more like a series of gates than it
Yep.
is like any one test. And so you have the tests that you do in the early stages, you got to pass all of those. And then you just kind of keep moving through more and more, higher and higher hurdles, I guess would be another analogy for that. Um, and basically, you just get to the point where you have nothing else you can really test, or
Yep.
you're starting to kind of really nitpick things. And then to me, it starts to become unfair for the athlete that you're asking
Yep.
them to do things that may not really make a huge difference for them.
Yep.
The thing I like to think about, and maybe I've been responsible a little bit of the abolition of the manual muscle tests of being like the absolute
Yes.
worst, terrible thing. And I kind of come around and go, well, I can defend the manual muscle test. And the way I can defend it is if I do a manual muscle test on somebody's quadricep and they fail,
Yep.
I clearly have a problem, and the
Yes.
manual muscle test was very effective.
Yep.
The problem is that just because they passed it,
Yep.
it doesn't mean that they truly passed it. But I use that same idea as we go to more and more complicated tests. Is the way I put it is you can only fail a test, you cannot pass it. So if they
Yep.
fail it, then I know I got a problem. But if they pass it, there's some subtlety there, and maybe my test isn't really looking at the thing that this person is really having a problem with. And so
Yep.
always kind of thinking of, all right, well, that test didn't show me anything. That's why I like to phrase it. Now I need to go and see if I can find any other test that would show me something, because
Yep.
it's not a pass fail. It's more a, ooh, that didn't show me anything particularly useful. Let's move on to something else.
Yeah, interesting. So, because I think in hearing that, there's probably a lot of clinicians, even myself at times, where we kind of, when it comes to quad index or hop test and that kind of stuff, where there's inherently this sort of teaching that goes on, at university level and even in some early career teaching courses where ACLers, for example, need to get a 90% pass mark to return to play, or they have to have this limb symmetry index that sits within 10% of the other side. So you're saying that that's probably not necessarily the be all and end all. It's not what we should be chasing.
No, and I mean, I deal with professional athletes, and sometimes, some of them have all the money in the world and they're not particularly worried about rushing back. But I have others that are like, look, if I don't get back by this date,
Yep.
I lose my contract, and now I got to go find, I run out of money really fast here. They're
Yep.
really, paycheck to paycheck type of athletes. And
Mm.
so sometimes it's a matter of, look, they're going to play on this date.
Yep.
Now, your job is to make it that they can play as safely as possible. So the way I always put it is there is no like one day you're not cleared, the next day you're cleared. It's more a
Yep.
matter of this kind of, spectrum as they're moving towards back to the way they were prior to the injury. And we're just trying to be very aware of where they are at any given time, and
Yep.
then make sure that they're acutely aware of what their limitations are. So yeah, they could go back with a 70% quad index, but
Yep.
they're going to be acutely aware of how that would show itself in the middle of a game, and what
Yes.
types of activities to kind of shield them from, and make them educated on that perspective. And to me, that's like what I said, every case is different. And so that's also every return to play is different.
Yep. Would you, with that example, for do you talk, because professional athletes don't largely want to sort of talk, they want to talk more about the performance side of things. They're not inherently risk associated in terms of re-injury. They're probably, vast majority are probably not that worried about hurting themselves again. That may sort of center there in the back of their mind, but they're more so worried about, will I go out and, put on 50 points this week and the next game. Do you talk about that? Like for, that from your physical therapy hat, like is that part of that conversation that if someone is, yep, really stubborn, saying, yep, I'm going to go back to sport on December the 1st, I'm only 7 months, I'm taking that risk. Is that part of your conversation in the whole well-rounded point of view?
Yeah, and ideally, if you start on day one with your testing and showing them where they are and where they're trying to get to, and then, you have a lot of time with them, you should be having these conversations all along of
Yep.
like, from a performance side. And we talk deceleration, hard deceleration on day one as
Yep.
being the final thing that they'll get. And we talk about that from a performance perspective, your ability to decelerate hard so that you can change direction in a high performance environment is really key, usually really key for their sport. It could be a sport that it doesn't matter so much. And we definitely get athletes that it's just not part of their game.
Yep.
And so it's not as much of a concern. But and then we move them towards those tasks that we show them. There should be a task at any point during the rehab where we're able to highlight the deficit that they have and how it applies to task.
Yep.
And again, those later stages, it's like, all right, go at a full on sprint. A 505 test is one that I've championed for a while as a great way to kind of really show that athlete where their deficit is,
Yep.
because they just can't put it together if they don't have that anterior knee force production, that quad index.
Yep.
And it's usually unnerving to them, and they don't
Yep.
like the idea of having that deficit. And um, either, like I said, you have an athlete that they have to play with that
Yep.
deficit. We'll
Yep.
show them, you see how bad you are at this thing. Here's the types of plays or situations where this is going to come up. In
Yep.
those situations, you're going to have to pull yourself mentally out of the game to protect yourself,
Yep.
which is going to be, a hindrance, but it is what it is.
Yeah. Have you had anyone change their mind along the way? If they've been firm on a date and all of a sudden they're now sort of getting a week or two out and clearly seeing that they aren't physically or mentally ready? Have you had
Yeah,
examples like that?
interestingly, especially the ones like I haven't been working with them and they're just coming in for a test or something.
Mm.
Usually the one that does it for them is actually the concentric isokinetic at 60 degrees per second.
Yep.
So it's a pretty slow test. This
Yeah.
people get all into like, well, it needs to be functional speed and whatever. It's like it needs to be slow enough that you can actually show the deficit. If you
Yep.
get too fast, the good side is having a hard time keeping up and you get a false sense of symmetry.
Yep.
And so doing that really slow test, a lot of times they can feel that it just the leg just doesn't give it to them what they're looking for. And they're just like, what was that? Like, what was wrong with my leg? And
Yeah.
they get that kind of weird feeling. And then you show them, the force position curves on it. And I've had several where they're like, no, man, I'm 100%, I'm great. And we put them on that test and they're just like, I don't, that just went horribly. Like, I felt
Yeah.
really bad doing that. And, you get the rare case that's like, well, I'm just never going to do that again. And that's their solution to it. Most of them are like, I don't like the fact that I did so poorly on that side compared to the other side. That's the
Yeah.
other thing that's stark for them, the stark difference between one side and the other.
Yeah, cool. And that being said, actually, we're going on complete tangents here because I got a list of questions and we haven't even got to the first one yet. I just like just letting this flow because it's really good conversation. It's the there's been certainly a shift, probably even for me clinically, there's been a shift a bit more towards just through matter of convenience. We have an isokinetic machine downstairs in our clinic, but to go, downstairs, do the whole, half an hour to 50-minute kind of process to do an
Mhm.
isometric test at 60 degrees knee flexion angle and do three, 5-second rep max tests at various varying stages. It's just nice and quick and clean. Do you see, with your experience, do you see obviously a big difference between those two testing parameters? Because I've done both, and I agree with you that 60-second test, sorry, that 60 degrees per second test, isokinetically, concentric, it sucks. It's hard, it's so uncomfortable, and then compare that to like an all-out effort at 60 degrees. There's definitely a difference between the two. Do you see, and have you got any feedback from athletes about the differences between those two test setups?
Yeah, so there's a few things there. It's when we talked about that kind of like the series of gates. And so if you can't do a 5 second isometric, you can't get within 90% of the other side over 5 seconds.
Yep.
You already know what you need to know that they
Yep.
have a problem. But if they're able to get that, then the question is, okay, well, when do they get that? And so
Yes.
what's happening in the first 200 milliseconds? What's happening in the first 400 milliseconds? These types of questions. And so I can often pick that up. And a lot of times what the isokinetic at 60 degrees per second is picking up is both peak and rate in
Yep.
one number. And so it's this person who has, quote, strength because they can get it if you give them enough time. And they're the ones that they just move slowly through their tasks and they feel symmetrical. They feel pretty good. And then when you have them do it at 60 degrees per second, because the device is moving away from them that continuous speed and they have
Mm.
to continually be generating the initial onset of kick,
Yep.
that's where all of a sudden they just feel really weak and it feels weird because they're just not used to it.
Yeah.
But, to that point is if you're looking at rate isometrically, you should be picking it up there
Yep.
as well, keeping in mind that that's only at 60-degree angle
Yep.
with your
Yes.
isometric or 90-degree, whatever you're testing at,
Yeah.
where you may have issues further through the range, and that's where that full arc one would
Yep.
show you. But if you've already failed the first test,
Yep.
you know, my rule too is because sometimes it's like I won't even do a test
Yep.
because I can already see like it's awful. Like
Yep.
your quad force output is awful. I don't need to measure it. It's just awful. And
Yep.
if you can't see it, then let's go ahead and measure it. But if you hear what I'm saying, talking to the athlete, then we got it. My rule is if a test is not going to change your plan of care,
Yes.
depending on the results, then don't do the test.
Yep.
You already know what you got to work on. It's fine. So
Exactly right. And I have these conversations a bit with some of my patients, also early career clinicians who may come and shadow for a day or a week or something. And my first 6 weeks with an ACL patient, I know their other side's going to suck, and they're going to be sore, swollen. You can see even sitting on the edge of the bed, they sort of get that kind of 90 to 30 is okay, but that last little quiver and that little bit of voluntary muscle shaking at the end. I know their quad output's going to suck, and it's like, I could measure something today, but it may depress them. It may make them, really annoyed and, feel overwhelmed with what mountain they
hmm
need to climb. So I'll sort of take that one as it comes. Some people I'll test because they just want a number to sort of benchmark themselves. Some people it'll probably just make their headspace terrible. So I just sit on it.
yeah.
So it's a person by person case when we test in the first 6 to 12 weeks.
Yeah, really, the only reason to do it in the early phases is just getting them used to the setup and
Yep.
getting used to doing it.
Yep.
But what I will say is I will start them on because usually in those early phases, especially the first couple of weeks, they're pretty sore.
Yep.
And so what I'll say is we're not even measuring your force output. We're just measuring how much you feel comfortable with.
Yes. Yep.
And we already know it's going to be bad. And so they're not put off by a really low number because they're like, oh, I know it's real. I just had surgery. It's like, yeah. And then
Yep.
you can kind of take that and kind of coax it along. Um, I might not even look at the other side because that's where they'll get like, whoa, that's a
Yeah.
huge
Really.
difference. And that potentially can send them back.
Yeah, and it can be. I often use it for biofeedback purposes. If you've got the any kind of setup where you can see some force curves or you can see some numbers that dial around, and you get that initiation of their ACL leg, you can see it's not that painful because a lot of people are fearful to even initiate a knee extension with a patella tendon harvest or a quad tendon harvest or whatever it may be. And it's like, well, here we
Mhm.
actually can start doing this test. We actually can start doing this as an exercise. It's not going to blow your knee up. Like it can be part of like a useful treatment, but it's just the numbers that you get, do you matter?
Yeah, I love using it. And actually, I'm a big fan, especially in the early phases, of just a long 45-second hold.
Yeah.
That classic 45 seconds on, 90 seconds off, and
Yep.
just do, up to 5 reps of that. But what I like about it is usually on the first one, they'll say, this is all I can do. This is all I can tolerate. This is it. And then by the third one, you're getting a number that's way higher.
Yes.
And so then it's a little question of, just asking the patient, what's happening there? Like, what was going on in that first one? Because when you felt that pain, you probably thought you were damaging something, but were you damaging something? Look how much higher you are now, and now
Yep.
there's no pain or less pain, or let's go back to that original number. Just hit that number. Don't go any higher. And let them kind of explore that. Oh, this is a variable response I get, and it's not necessarily consistent. Meaning, I don't need to freak out just because I have some discomfort. It could just be, a hyperprotective nervous system or things like that. So let them kind of reckon with that a little bit. I think it'd be helpful too.
Yeah. Awesome. Well, we might as well start getting through some of our questions now that we're sort of leaning into that little bit. It's a nice little segue into probably one of the first ones. Like in the early phases after ACLs, do you have any particular non-negotiables? let's say the first 12 weeks? Are there things that must be included in your management plan, be it, cryotherapy, electrical stimulation, blood flow, quad setting, any of our kind of, physio tools? Is there anything that just must be done and everything else is surplus?
I always think of like that old 80-20 rule, the 20% of the work that gets you 80% of the results.
Yeah.
Obviously that's just a rule of thumb. We don't know how accurate all that is, but I think of the 20% of work that's going to give you 80% of the results in the early phases is swelling control,
Yeah.
getting that swelling down. So, the swelling makes the muscle not want to engage. The swelling makes the range of motion not want to happen.
Yeah.
The swelling drives pain, all these things around swelling. So, whatever you can do to get that swelling under control. So, elevation, compression. I still like putting an ice pack on there
Yep.
mainly because they feel good doing it. And so
Yep.
if that's the only reason, some people are like, oh, we need that inflammatory response, we need the inflammatory response, and ice is anti-inflammatory. I'm like, it's not steroids. I mean, what do you think ice is doing? It's not, it's barely having an effect on that's the whole point. It doesn't
Yeah.
do that much,
Yeah.
but
Yeah.
it helps them feel better. And on that same note, if putting some like IFC stim on it makes them tolerate the position longer, then let's do that.
Yep.
As long as we're not selling it as doing anything it's not doing other than this just might make this feel more comfortable. And if you like it, here we go.
Yep.
So that would really be my non-negotiable because it gets me so much more. If I see that thing is chronically swelling, I'm going to be really checking on how much are they up on their feet? How much walking around are they doing? Let's really back off the activities because it's probably the big thing there.
Yep.
I've actually, kind of thought out loud about, I wonder what would happen if I just had somebody for 3 months do nothing but swelling control
Yeah.
and basic range of motion, where I would be at 3 months. Would I
Mm.
be really behind, or would I be weirdly presented with a knee that's ready to
Yep.
go pretty quick now from that point? As opposed to the beating on it, trying to get, oh, let's get some muscle activation. Let's
Yep.
get some load in that leg. Let's work on weight bearing and all this stuff. And it just makes it angry.
Yes.
So that would be my big thing is just that.
That'd be a fascinating study. And yeah, I do wonder too, because I mean, we see that muscle just, drift away on us immediately post-op, right? We get that muscle inhibition response. But, you know, you, that this sort of as if the muscle is just like completely shrunk. It's just or it's just got lost that muscle stimulation, right? And it's got that, it's inhibited by the nervous system's just being impaired at the moment. So it's not as if the muscle unit has completely disappeared into thin air. Like it's going to be
Right.
sitting there. It's just not very well excited. So if we control the pain, control the swelling, we do some basic, movement, just gradually load it. Yeah, you're right. I wonder, do wonder, do we end up at 12 weeks and we're probably within 30% of the other side naturally without working too hard, maybe 40% without working too hard. And with also too, just not having to, I think about some of the patients, how much money they spend in the first 12 weeks, coming in to see me in the clinic,
Yeah.
like, and just that early days, those fears of, they see people getting treatment. They've heard their friends getting treatment and they've got this apprehension and fear that you're just going to start jumping up and down and mobilizing their knee and the whole process is going to be painful. It's
Yeah.
like, there's this really unsettling,
Well, I used
nervousness.
to tell patients, come in and see me when you feel like you're ready, for
Yeah.
the first one. It's like, take what the surgeon gave you. So some basic range of motion, some swelling control. Maybe, when you feel like getting out of the house,
Yeah.
come on down. We'll do a session. And that session is just going to be all about saying, hey, it's okay.
Yeah.
Let's find what feels right for you. Let's find a good schedule for you. And then maybe come back in a week or so and let's just see that your range of motion is improving.
Yeah.
And it can be as simple as that. And then, yeah, once you hit 3 to 4 months, now you got some stuff to play with. That
Yeah.
could be definitely something. I mean, I know like with, AMI, that arthrogenic muscle inhibition, which is what we talk about, the joint is telling the muscle, hey, back off.
Yeah.
It's a protective mechanism. It's the easiest way to unload the knee is to shut the quad down.
Yeah.
Then it's going to keep you from doing activities that really load the knee. So this is where I don't really vilify the AMI so much. It's not
Mm.
like, if we could just get around that. It's like, if you could just get around that, you would destroy that knee. You
Yeah,
would be
exactly
so
right.
angry.
Yep.
So, it's okay. And, we have things like BFR and NMES and, it's kind of the idea of like trying to like do CPR on a muscle that doesn't get a stimulus otherwise because the
Yep.
joint just really isn't letting it. And I understand that argument, and I'm not opposed to it. I'll say our high level athletes for sure, they're offered it.
Yep.
Both of those interventions are classically uncomfortable when
Yep.
done properly.
Yep.
And some athletes are like, man, if I don't have to do this, I'd really rather not. It's like, well, I'm not, like you said, the non-negotiable. It doesn't really fall into that.
Yep.
I've
Yep.
been doing this long enough that I've tried it with and without, and and there's some recent studies that have just come out where they've
Yeah.
been pretty good about the process. And when you read those studies, kind of the conclusion is, I don't know if many of our interventions do a whole heck of a lot
Yeah.
at all.
Yeah.
It's not really a knock against BFR or NMES. It's just, I think this thing's going through its process is the way
Yep.
I see it. And so just how can I stimulate it, do what I can, and then get it back later if at all costs. So
Yeah, yeah, that was one thing we recently shared on the hub was that yeah that recent paper from Brian Noren's team is
yep.
and Lynn Snyder Macklow alerted me to it. She was saying that yeah BFR added not that much extra value if we just got our loading right and we just
Yeah.
did really good high quality supervised exercise training in the first 3 months. Yeah, obviously let it settle, let it sort of recover and lick its wounds in the first few weeks, and then
Yeah.
let's just start loading sensibly. It's not
I
necessarily
mean,
rocket science, right?
we just talked about it being a protective mechanism, and so what we have to do is convince that protective mechanism that it's not necessary.
Yeah,
So it's afraid of load to the knee. So what we have to do is try to find that sweet spot of load so the nervous system starts going, okay, well, this load seems safe. I'm going to go ahead and allow that. And you just try to do that kind of, sequentially as you go, and understand that that could be a 9 month process.
yeah,
Um, the idea of like the CPR side of things, I'm, like I said, I'm not opposed to it. Um, and I think that was that study with Noreen where they showed like initially you notice a difference.
mm,
They're doing better, but then as you follow them through towards the end, they kind of even out as far as the
yeah,
timeline is concerned. And
yeah,
it's the way I like to think about it is in an ACL rehab, there's like the real timeline. So what the knee really can do, there's a line there.
yeah,
And when you first come out of surgery, what you think you can do is way lower than that line.
yeah,
And so I think what happens is when you do these things like NMES and BFR, which create a pretty strong stimulus to the muscle, I think you run up against that line of what you actually can do pretty quickly. And so you get
yes,
this really big burst of progress and then you stall out.
yep,
Without doing those things, what I find is that stall happens closer to 4, 5, 6 months out, where all of a sudden now they've caught up and then they're just kind of stuck there and they're not making a lot of progress.
yep,
I think you just hit it faster with those other
yep,
interventions.
yeah.
Yeah.
Yeah, interesting. I love that reference to CPR. It just gives me a really nice visual of just trying to just pound on the chest of this or pound on the knee of this muscle, just with
Keep it
all
from wasting away on you as best you can.
yeah, let the record show we're not getting it mixed up with BFR. We're taking the piss by calling it CPR. That's awesome. Very good. Well, yeah, personally, I don't use much of it at all. I think probably there's been maybe 5 or 6 cases in my past where I thought, you know what, I probably could have started BFR later. I've just been a huge advocate of just the same approach as we've discussed today. I've had a lot of people say, why don't you use BFR more? It's like, well, it just adds an extra layer to my patient's rehab early. They got to come in twice a week. If we're following strict protocols, they got to come in for supervised physio twice a week for 6 weeks, and it's cost. And if we just load up sensibly and introduce things safely and sensibly, we'll probably end up at the same spot. And it's usually the ones that have just got a bit more of a history with patellofemoral joint pain or maybe some osteochondral things where I thought, oh, maybe we could have sort of softened the blows a little bit earlier by adding it in. But yeah,
Maybe.
very few and far between that
I
I've
mean,
met.
the way we use it the most right now is with our higher level athletes. They'll use BFR like at home. They'll do that
Yep,
IPC program where
yep,
they're just inflating for 5 minutes and then deflating for three, inflating for 5 minutes, deflating for three, just
yep,
trying to get that systemic effect.
yep, yep. Cool. On the knee extensions, I know you're a big fan of the quads and getting them going, and I know they've sort of copped a lot of heat in the past. How does your first 3 months of programming look in terms of knee extensions in your athletes program? Are you full range from day one, or are you reduced range? What does it look like to you and your cohort?
Yeah, so we start with isometrics right away, and that's down at 60 degrees with us, usually 90 degrees for home program.
Yep.
I do partial arc, weighted.
Yep.
Um, I don't do full arc, and some people are like, oh, do you think it's, dangerous? It's like, no, I just think that it's a waste of time because when you look at the force position curve, they're not particularly strong close to full extension.
Yep.
And so if you're trying to if you're loading them light enough that they can get to full extension, you could be adding a lot more load to that system
Yep.
and just shortening that arc up. And so I
Yep.
will say we kind of stay partial arc through the whole rehab,
Yep.
but it's not because and that's isotonic. If I'm doing
Yes.
isokinetic, let's go full arc. Let's
Yeah.
let it rip. But I usually wait until like 3 months out just to
Yep.
I got plenty of other things to work on in the meantime.
Mm.
So we tend to do it that way. But
Yeah.
yeah, isometrics right off the bat, and then we'll introduce partial arc. We do partial arc in the even in the ice kinetic machine actually for the first 3 months, just because we can get a lot more engagement from them in the
Yep.
partial arc.
Yep.
Um, this is where I tend not to do a lot of like terminal knee quad extend or quad sets or like straight leg raises because it's a quad isometric, but you're doing an isometric at the end range most contracted position,
Mm.
which, I mean, you wouldn't do that in any other muscle. If I
Yep.
was going to work my bicep
Yep.
isometrically, I wouldn't bend it to full flexion and they go, all right, work there. Wow, look how weak you are. It's like, yeah, no crap. Put me in the mid range where I can perform. And for the argument of, well, they need strength at the end range. It's like, do they? Think about that. That's not a position that the quad gets loaded, even during gait. It's not it's a vertical ground reaction force. It's a very small moment arm in that position. So, if you get them stronger in the mid range, they usually will get
Yep.
it
Yeah.
everywhere else too.
Yep, very cool. And say like sets and reps, for example, are you kind of in that low, light and easy kind of 3 sets of 15 kind of stuff? Or yeah, what does that kind of look like for you in the first 12 weeks as well?
Yeah, those isometrics are doing those long haul 45-second, 90-second rest breaks. And that's more from the perspective of I think this person is limited more by fear and sensitivity than anything else. And I think long holds gives you that quote safety factor because you don't have with all that time, you just can't really get very intense.
Yeah.
But then we would shorten that to, higher rep, short bursts, like 5 seconds or so.
Yeah.
But I'm a big fan of trying to get that weight up. Because ultimately, when you think of the quad index, it's that max force output is what we're
Yeah.
looking at. So it's a 1 rep max basically is what we're trying to push.
Yeah.
So trying to bring the intensity up with the rep count down,
Yes.
of course, assuming it's tolerating it.
Yep. Yep.
So
Yep.
it's as heavy as tolerated, and then we look for fatigue factor. So,
Yeah.
as far as sets and reps, I find that people knock 3 sets of 10 because it's like you're not thinking, but it's
Yeah.
also if you're loading appropriately, they should be fatiguing around 10 reps.
Yep.
If you're going for like a 5 rep failure, you're probably not going to get that in the early phases because that's a lot of intensity.
Oh, wait. Yep.
And that muscle, like I said, the muscle is stronger than what it's tolerating through the system. And so, we tend to be more 10. Sometimes they are 15 just because it
Yep.
is that much of a difference. So.
Yeah. And do you see much of a difference between your graft types in those early stages too? Are your patella tendon autografts less tolerant to that heavier stuff early? Hamstrings a bit happier with those heavier loads? Are you seeing
Yeah, I
a
mean,
trend?
hamstrings are very happy usually,
Yep.
just in general. And I think that's one of the reasons. I don't know if you guys see a lot of LET over there where they
Heaps.
do that.
It's
Yeah.
pretty much routine now. It
Yeah.
used to be saved for really high risk recurrences, but now it's like primaries being added
Yeah, some studies are coming
regularly.
out showing that it kind of reduced the second injury rate on the hamstring grafts to
Yeah.
be matching what the quad tendon and bone patellar tendon bone second injury
Mm.
rates. But I think to give proper credit, I think it was Lynn Snyder Macklin has pointed this out that the big quote problem with the hamstring autograft is that they're more comfortable and they get back faster.
Mm.
And that
Yes.
probably is what the risk is. Now, what does the LET do? Well, it
Mm.
slows them down by about 6 weeks.
Yeah.
And so it may have nothing to do with the LET, but now we're throwing an LET on like the patellar tendon bone and the quad tendon. But actually, I find probably the group I'm going to be most aggressive doing quad isometrics on early is bone patellar tendon bone
Yep.
because their sensitivity is such a problem and they'll develop that patellofemoral pain by not loading it early enough.
Yes.
You
Yep.
know, unload it for a while. It has all that trauma to it from the surgery, and then don't load it for, 3 months and then let her rip. It's just a recipe for an
Yep.
overblown patellofemoral joint. So definitely hit those early. And then those quad tendons, man, I don't know your experience with them, but they're cranky.
I hate
Um,
them. They,
yeah,
they,
they just they just fight you. Yeah, I've they've been a challenge because finding that because some people say, yeah, you just got to be really careful when you start loading them because they're so temperamental.
Mm.
Well, that's what we used to say about bone patellar tendon bone as well. So I think maybe the opposite. But it seems like no matter what we do, when they're out towards 6 months or so,
Yep.
that quad tendon is just angry and
Yep.
their quad index suffers from it.
Yeah, agree. Yeah, I haven't had where I'm working now, mostly hamstrings. There's one surgeon who does primary patellar tendons, which I love. I used to
Mhm.
really not enjoy them where I was working in Melbourne, but yeah, there's a guy up here and he just loves them, and I love working with them. Quads, I don't see too much of, but yeah, the ones that do walk in the clinic, yeah, I just know they're going to be hard work.
Yeah.
Yeah, their returning quad strength just takes so much longer. They're just crankier along the way, probably just a bit
Yeah, they're
slower through their
they're becoming
progress.
less popular here in the
Yep.
US, I think because
Yep.
of those problems that we've been having with
Yep.
them.
Yep.
I take whatever I get,
Yeah, that's right.
obviously it's like pick your poison, they all have an issue, but um yeah, they seem to be the most temperamental and I unfortunately I don't have a good answer right now.
Yeah.
They all just seem to be cranky at that point.
Yeah.
Um
Yeah.
yeah,
I've seen, I've
and then
seen,
magically they do better
yeah,
after a
I've had
while.
a run of allografts lately and a lot of in probably about 6 or 7 non-professionals, all kind of 30s, 40s. I've actually been a joy to work with. I know there's,
Cakewalk.
oh, far out. Like they're out of the blocks beautifully early. There's no other harvest issues. And just the fact these guys are just guys and girls, they're just not keen to go back to pivoting high risk sports. So it's like, all right, you guys are just cruising, like it's yeah, they're a joy.
Well, and what I like to point out with those allografts, remember what I said about the hamstring grafts?
Yeah.
What might be the cause of their second injury rate is that they get back so fast. Now think
Yeah.
about the allograft.
Yes. Yeah.
I think maybe the allograft gets a bad rap because of that being an issue, them getting back so fast. That said, the allografts also sometimes just disappear. The
Yeah.
body just
Yeah.
reabsorbs it, and that's
Just
obviously not going to be a good outcome.
not going to be a great result. No. How do you handle and you probably don't have too much of an issue these days, but any advice for any early career clinicians who are just dealing with surgeons who are just against knee extensions? Have you got I don't have an answer for it. I've been asked so many times, like, how do you manage it? It's like, well, I'll just do it because I can, and I've probably, worked around enough. But there's going to be people who are 1 year out, 2 year out, who just don't have that confidence just to have them in a protocol. Do you have any ways around that or any advice?
Yeah. First off, your nomenclature.
Mm.
So you're not doing open kinetic chain early. What you're doing is quad sets down at 60 degrees. No surgeon is afraid of quad sets.
Yeah.
Hey, can I do those quad sets with the knee bent? Yeah, sure, that's fine. Don't show them because it's on a leg extension machine. But just say, I'm gonna do quad sets, but at multiple angles. They should be fine with that. Because really, I mean, half the time your quad set isn't at full extension anyway, and so now you're right in the quite quote that danger zone. So that's the first thing is just change that nomenclature up a little bit. And then, like I said, I mean, I don't really go pushing for those full arc loaded leg extensions anyway.
Yep.
And usually, if you're going to keep it like from 100 to 60 degrees, you're going to be hard pressed to find a surgeon that's going to have a real issue with that. And even if you do, well,
Mm.
get out past the surgeon because usually the surgeon's going to cut them loose from their care, at least for a long chunk of time, and just, take it from there.
Yep.
There are
Yep.
things like wall slides on toes, like wall squats on toes, that kind of thing, where
Yep.
it's technically closed kinetic chain,
Yep.
but the biomechanics of it is an open kinetic chain activity.
Yep.
As far as what I'm really looking for, and I have a whole rant that I do about what even does that phrase mean, open kinetic chain versus closed kinetic chain. What we're looking for is to get the vector of the load coming in, whether that's ground reaction force or from a machine or whatever, to be perpendicular to the distal tibia. That's the thing that creates the large moment arm for the quad that
Yeah.
cannot be accounted for by the glutes, the hamstring, anything else.
Yeah.
That's the importance of it. And so you can get creative to find ways. Another one is doing a leg press, but in quadruped. So you put the
Yeah.
foot up
Cool.
high on the
Yep.
plate, and all of a sudden now you've got a leg extension you just created. And so
Yep.
you kind of play on the ignorance of the surgeon that they don't know that that's the same as a leg extension.
Yep.
As far as the foot, as long as the foot's in contact with the ground, they think it's safe.
Yep. Yep. Yep.
And
Yep.
so you just work your way around that. Yeah.
Yep. Nice. Nice crafty tips. Cool. Mate, moving on now to the kind of back end, so to speak, is the sort of 9 month return to sport figure that often is being sort of quoted. And I just reflect on what you were saying earlier about the ACL athlete who's, 7 months post-op, they're playing for their, next contract. Yeah, where do you, I guess, sit philosophically, or even with an evidence-based practice point of view? Like, does this magical 9 month figure exist in your daily practice? Is this something you work for and towards, or is it
Mhm.
something that you just sort of once again treat it case by case?
Yeah. So I was actually at a conference, not presenting, just out in the audience.
Yep.
And somebody in the panel was asked, what's the soonest you would let somebody return to play?
Yeah.
And I just started laughing to myself because I'm like, I know what everybody's going to answer. I don't think anybody's going to say 6. I think a lot of people are going to say 9, but then some people are going to put their foot down and say, I wouldn't let anybody go back till a year out.
Yep.
My answer is 4.5 months.
Yep.
And that usually like blows people's minds. I'm like, I interpret the question, I think, differently than other
Different.
people
Yeah.
because you asked is what is the soonest? So what I'm thinking is all criteria are met.
Hmm.
Everything is checked off. This person has an amazing quad index. They have rate, they have power, they've got everything.
Yeah.
If it's only 4 months out, I'm not going to let them. That's what I'm saying.
Yeah.
At 4.5, I'm starting to go, we may have enough going on. I would recommend an MRI to look at, graft maturation.
Yep.
Maybe this person's just a freak of nature. Why would I hold them out, if
Yeah.
they've got all these other things? And there's that recent study at Aspetar, I think Rula Katsasvaki was
Yep.
the lead author on it that
Yeah.
showed if you just go by criteria,
Yep.
the time doesn't really seem to
Time doesn't
matter. They
matter.
had people
Yeah.
getting back like at 7 months, and their second injury rate is the same as long as you are doing your proper testing battery through that. And
Yep.
the that lowest hurdle is that 5 second quad index isometric.
Yep.
And some people jump up and they're like, well, wait a minute, they don't have rate, they don't have, it's like that's all true, and those are all definitely I would consider risk factors.
Yep.
However, if you can't do 90% over 5 seconds,
Yep.
you're trash.
Yeah.
Your risk factor is crazy high. That's why
Yeah.
that's such a big first hurdle for that. But and that's where you'll see a lot of the research with around that. A lot of their criteria is isokinetic because it captures rate,
Yes.
and
Yep.
there is no really good way to consistently get a consistent rate number
Yep.
outside of that isokinetic where the rate number is buried in with the peak.
Yep.
And that's where I think that can be a little more sensitive test. But yeah, I think testing's bigger than time because I've also had athletes that are close to 18 months out, and I'm just sitting here
Yep.
going, I don't know what to do with you anymore. You
Yep.
you stuck. Your knee keeps swelling. It's just,
Yep.
I've had cases like that where we're like, look, they're a college athlete. They're on a scholarship. They need to play. Let's start
Yep.
integrating back in immediately. They tear the other side, and we're just like,
Yeah.
and part of me is like, well, I could have sent them back at 6 months
Yes, that's right.
because they're going to tear it anyway.
They
And
haven't
let's get
changed. They
started.
haven't changed. Yeah. 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 Yeah.
Now a whole year has gone on top of it, and they're
Yep.
starting over again. And so, it really makes me, really think, if you're writing that criteria, looking at the athlete's individual situation, as far as their sport, where they are in their life, you
Yep.
could have a high school kid that they're never going to play competitively
Mm.
again. This is
Yep.
their last chance. You might let them get back out there
Yep.
because, this is the last chance to really play competitively. They're not going to go to the next level.
Yeah.
It's always, a little conversation to have.
Yeah. No, it's interesting insight because it's yeah, I was talking to Ender King last night and he was
Hmm.
yeah, he was sharing those insights that yeah, so, 6, 9, 12, yeah, it didn't particularly matter from their work. So it's definitely yeah, it's making us think. I think probably for us working in the non-professional side, it kind of gives us an excuse just to sort of buy time, aim for 9 months and just gives us a few more things to sort of sleep well at night. But definitely in the non-professional world, if you're working with elite athletes who have got, a few more bigger picture things and a lot more key stakeholders and sponsors and career contracts and all these kind of things, there's definitely a lot more wiggle room. And as you said, let it be guided by criteria. There's a few cases here locally in our professional competitions here in Australia where the athletes have got back at 6 months and have done so swimmingly.
Yeah.
So yeah, definitely the elite world is a different ball game.
Yeah. I tell
Non-professionals,
everybody plan for 12.
yeah,
If they're an athlete that's very secure in their position, like they're not worried about getting cut, they're not worried about a contract or anything else,
yep,
I say just plan for 12. It might take longer, but let's plan for 12 and let's just take advantage of the time.
yep,
When have you had a whole 12 months
yeah,
to not have to play? Let's work on, if they're a basketball player, you better be the best free throw shooter on your team come
yep,
next year because
yes,
now you can work on your skills. You can work on like let's take advantage of this
yep,
break to work on all this other stuff
yeah.
and really try to, again, take advantage of that.
Yeah, no, that's a nice message there. Are there, speaking about criteria, is there a key list of things? I know that's probably a loaded question as well. Lots of things you probably would make your athletes jump through. Obviously, athletes get different tests. You probably alluded to the isokinetic test being at least one of them. Are there any other, hopping, jumping, 505 tests obviously is something you've sort of spoken about. Are there any key objective tests that you would want and these hurdles that you speak about? Are there key ones that you want them to pass?
Yeah, so definitely the first one being that quad index over 5 seconds isometrically. I think people are surprised how long that actually takes to
Mm,
get up over that. It's not uncommon for that to be 9 months before they get to that. It's usually around 6 is what I find because they'll stall out. They'll get to about 80% and then get stuck for a couple months, and
yeah,
then they get the last 10% to get up over. So that's the one, and then I don't know what reporting you use, but with our old reporting, I never liked the actual numbers on rate. So we literally would just be looking at the forced time curve of the isometric and just look to see how they're lining up. Now we get a quad index at 200 milliseconds and a quad index at 400
yeah,
milliseconds. That's on the HUMAC norm software. So we get that little snapshot in there. And then we're looking at the isokinetic at 60 degrees per second. I don't look any
yeah,
faster than that.
yeah,
If they look clean on the isometric, where the two curves look pretty symmetrical,
yeah,
and we're within 90%, and then I look the same, but they look the same on the isokinetic at 60 degrees per second. They're within 90%. Usually they're gonna have a little more asymmetry there. They'll definitely have a lower peak just because
yes,
isometric allows you to get to a higher number. That's one of the reasons we use it. Um, then I'm like, you know what? I can't really see anything else with this machine. I need
yeah,
to now go to something else. But again, this is often, 6 to 9 months out before
yeah,
that all looks cleaned up. Then my personal tool has been the 505. So doing, it's max effort sprint into a 180-degree change of direction, sprint back out, and you're getting the turn to the right, turn to the left. And what always blows people's mind is that the challenge is not the plant pivot. The challenge is the decel
so
turn in, and so it's the inside leg, not the plant pivot leg, that creates the problem. And it's actually a blog post I keep meaning to write because I've been talking about it for a while, and I should just put it on a blog post because it always seems like when I put it on the blog post, that's when people are like, "Oh,
oh,
it's like, well, I've been saying it for a while. This is not new." But I have tons of pictures of people in the middle of that plant pivot, and you could see the contralateral side is the one that looks horribly ugly
Yeah.
on the plant pivot. And it's because the surgical side did not decelerate them. So they're trying to do way too much with that. And to me, that's a big possible reason for the contralateral ACL injury after, primary injury. And it has nothing to do with the contralateral side. It's all because of the surgical side not doing its share and just dumping the load into that contralateral side. You hear the change of direction folks talk about at high speed, the plant pivot leg should not be decelerating. It should be planting and pivoting, and asking it to decelerate and plant and pivot at the same time in a high intensity situation is just a recipe for injury.
Yeah.
And I think that's kind of what we end up with. And so the 505, because there is no real hard, I mean, I've been using it for a long time. So I've got things that just over time, I know what I'm looking for. Talk to the change of direction folks. They'll talk about like what, take that snapshot of the plant position, look to see that there's a straight line from the foot to the head.
Yep.
And if there's any vertical part to the trunk, what it
Yep.
means is that the mass has not been controlled.
Yes.
The momentum of the mass has not been controlled by the time they're planting and pivoting. And so that's the indicator you look for. And I'm looking just for symmetry. How do you do on the left? How do you do on the right? And also qualitatively of just saying, quantitatively, we're looking at the actual score they get, left versus right.
Yep.
But then also just asking them, how'd that feel?
Yep.
I felt slow. I felt sluggish on that side. I just feel like I'm nervous when I go to that side. So this is all good feedback to get.
Yep.
But I go back to our, force reports and go, well, it says they should be able to do this. Maybe it's just a matter of practice it.
Yeah.
And if my S-kinetic test said that they shouldn't be able to do this, I should not be doing a 505. So the thing that always confuses me. It's just like, why did you do that test? I do recommend to sports teams that they do a 505 as a baseline as part of the preseason, because sometimes they use different strategies going left versus going right. And some people say, well, that's not right. This strategy is bad. It's like, that may be, but it's what they use. And when I'm doing rehab, my first job is to get them back to what they were.
Yep.
Then if I'm going to change that, I need to start talking to the performance staff of, does it need to change? Because this gets into all the uniqueness of individual athletes. Sometimes you're dealing with an athlete that, when they go left, they do this other little weird thing, but that little weird thing that they do gives them advantage in the game.
Yeah.
And it's actually not a safety issue if it's never shown itself to be a safety issue. That's the
right.
catch-22 with it. So
yeah, you got to be careful to try and correct things that don't need to be corrected, right? So it's some of these, like I look at our rugby league, like rugby league AFL athletes here in Australia, like we sort of valgus and dynamic valgus has been sort of really sort of feared, but these people that are cutting at tremendous angles, that's what makes them great. It makes them evasive and elusive. And sometimes like some people are just genetically blessed. They can just sort of get through unharmed, and to try and change that is going to take away from their performance aspect. It could mean the difference between them scoring points and them not. So
they may have a genetic predisposition that allows them to go into that valgus with that load profile and somehow survive it. And that gives them a huge advantage. We talk about that with baseball pitchers here in the US. They put so much torque on their shoulder that it would destroy most people's shoulders. But for whatever reason, their shoulder can take it, and there they are.
Yeah.
You wouldn't go, oh, that's a lot of load to a shoulder. We better. It's like, yeah, great. You just made them not be an elite pitcher.
Yeah,
that's what you've done.
You just made them lose $100 million contract.
Exactly.
Yeah. Is there any counter movement jump hop test things that you throw in as well, or no? Not something
No, the hop tests to me are an analog for my quad function.
Yep.
And so if I'm measuring quad function directly, I don't need to do the hop test. I'm a lot of people have gotten really like down on the hop test and I would only get down on the hop test if you're using it like all the time and they're learning how to do a hop test without a quad. That's a problem. But it taken on its own, not practiced, it's a pretty good mimic of a quad test. It's going to give you that perpendicular load if they haven't learned a hip strategy yet. So I'm not opposed to it at all. It's just, to me, they're analogs of each other.
Yeah.
Quad test versus hop, and then counter movement jump. I'm fortunate enough to work most of the situations I'm in. We have strength coaches and sports scientists that are doing counter movement jump
Yeah.
on a regular basis for tracking, for fatigue and all these other things. And so what I do is I'm using my tools. I get to the point where I go, you know what? I'm having a hard time seeing a deficit at this point. I feel like they're pretty good. Go ahead and do your counter movement jump with
Yeah.
them and see what we see. And a lot of times, if there is an issue, it's subtle, and it might just be a matter of, you know what? It's just they haven't done a counter movement jump in a while. Let's go ahead and
Yeah.
just, they're
Yeah.
ready for it now. Let's go and practice. So I'm a big fan of not letting somebody practice something that they don't have the capacity to do.
Mm. Yeah.
Which, as simple as that sounds, a lot of people are completely, opposed to that. They're like, oh, they should have been practicing counter movement jumps the whole time. It's like, why? They don't have the
Yeah.
quad capacity to do that. So unless you're going to modify it in some way, and then it's a modified counter movement jump,
Yeah.
what's the point of that?
Yeah.
And that's where, you could argue it, but it's like, to me, it's I like to hand it off to them, and
Yeah.
then have them come back to me. And I love leaning on my strength coaches and sports scientists. What do you guys see? Well, we're seeing this part of the curve, and that, to us, that's telling us that they're not quite getting their quad. And it's like, all right, well, let me double check the test. Sometimes we double check, and it's like, when we really push them, actually, we're finding that they weren't giving me their full effort on the good side,
Yeah.
and they actually do have a deficit. And so thanks for exposing that for me. But other times, like, no, it's actually there. Let's just see if we can cue our way through this on your
Yeah.
counter movement jump. And it's just a matter of confidence, or I'm a big fan too of just showing them the forced time curve in real time and just go,
Yes.
you see that little wiggle there?
Yeah.
Don't do that.
Yeah.
Like, don't even tell them what the wiggle is. Just go, make it not do that anymore. And amazingly, usually they can feel it. And it's like,
Yeah.
good, perfect. Thanks for
Yeah.
fixing it.
Perfect. Excellent. Excellent advice. Mate, I've taken a lot of your time today, and I appreciate it. We might wrap it up here. Just give us what, if we can, just closing, our clinicians that are early career clinicians that are tuning in today. Is there any pieces of advice, lessons you learn along the way, or pieces of advice you can share? ACL related, physiotherapy, life related, whatever advice you've got to share to
Yeah.
help our clinicians become better.
Yeah. It's have a good, solid process.
Yep.
That's what matters. That's what you're always going to run back to when things are not going well. I'll tell you right now, a bad outcome happens to everybody. Okay.
Mm.
We all get bad outcomes. It's being able to look at a bad outcome and say, I've done everything I can within my power, and this just is what it is.
Yeah.
Because I see so many clinicians, they just start panicking that it's their fault and that they didn't do. Now, it's possible it is your fault, but that's usually because your process wasn't correct. And you got, 9 times out of 10, when I'm working with a consulting case, what the therapist did is they went chasing the complicated stuff and just forgot about the basics.
Mm.
And so have your process keep bringing you back to the basics. That's really kind of the key for that. And I mean, that's true in all things in life, is just
Yeah.
don't make things harder than they have to be. Do the simple things exceptionally well, not
Yeah.
just a good job, not just a great job, do it exceptionally well, and you will be extremely successful in all things.
Yeah, great advice. I should listen to that, especially when it comes to baking. My wife reminds me about that all the time. I always seem to gloss over some of the basic recipe pieces of information, and my cake turns out to be an absolute pancake. So it's yeah, no, I'll take those lessons on board as well.
Yeah, for sure.
Don't overlook the details. Have a good process, mate. That's excellent. Erik, you've been wonderful as always, very generous with your knowledge and information sharing. And I think everyone today watching this would have learned a ton and has been able to take something to the clinic to improve their practice tomorrow. So, yeah, thank you very much, mate.
All right. Appreciate it. Thanks for having me.
Pleasure anytime. Always good to catch up. All right, guys, thanks for tuning in today. And yeah, watch out for the next episode of interviews on the ACL Hub. See you next time.